got paid?
I usually say when I drink vodka, I serve it less dose. And just all it is Rupert Murdoch's.
Remember when we were kids, we were going to have all the here's what give us serious music tonight. We didn't have to do something.
You know that, right?
There's also a technical design.
They used to media companies that see movies and present it to somebody through. All they need is to have somebody else, and you and you were talking about their bike and all this stuff. You just sorry, so sorry. That's what exactly. That
me like stay out of the like other group. I don't want to interrupt. I just have a lot of things to clear. Do you want me to clear after you're done? Or?
Is there any way that you can?
Yeah, I could definitely work it out. I could definitely do that. I just don't know if I get to over here, I'll be in the way.
Just go across the quickly. Yeah.
Okay, I just don't want to be there.
Sure.
yeah. Thank you. Very good.
Yeah.
Those guys, but they're the same. Murdoch, the Mercer said they're ahead of it because they know what they're doing.
This morning,
Now it's like
Actually, some large portions of the field are found. One of the evidence is a very, very large school.
Still might be
they were targeting apparently the military advisors gave Molly's options for DSD brand. Salamani was the last most egregious one. They thought they'll never go for this. Of course, surprise, surprise.
speculation.
if you ever see one.
Yeah, they have there's a they get partially problem. That's interesting. They also call it into their
Yeah, right.
it's about it's just
They saw something Well, here's the irony. Back in the day, Reagan, he sold on
Salamani was not in Iraq.
Right. That's right.
This is just a breaking story.
Right. But in the days of Walter Cronkite, whatever he said, and that's the way it really was. And if you think about it, it was a lot more focused and short. Well, that's what it is.
Yeah, but
They had some unspoken agreement between them that they wouldn't target each other's highest ranking or high ranking personnel. Question.
other night,
You got 950 movies a day on the screen. You can't even see them running the
Yeah, you got it. No, don't forget, you got to watch out for women.
It wasn't. I mean, he's not supposed to be there. That means you want to go about it.
Well, we're not going to reel things back yet, but
Was it something I said to you?
too much asked. But that's what we should be striving to do here. We have a lot of data. Making stuff up and perpetuating it. Making stuff up.
They are.
Sure.
I sent it to you.
The whole Oasis was destroyed.
About 64. You got the courage.
Hold on a second.
You got, yeah, I thought it was like 60, maybe 30.
You want to be up there or whatever?
I don't know how much the courage is. The courage is
maybe 30%, but they're up north.
right. Well, it's
So, here we are at the first meeting of the Chemical Consultants Network for 2020, and I wanted to thank you all for being here. The Chemical Consultants Network is a topical group of the Philadelphia section of the American Chemical Society. I'm really gratified to see a nice crowd here, including several members of the CCN steering committee, and we have the current chair of the ACS Philadelphia section, Joe Martino, and our past chair, Jim Murray, sitting over there. I just wanted to let you know that the Chemical Consultants Network is here to help people start, maintain, and grow consulting businesses in the chemical-related sciences, but we have not only scientists in classic chemistry, but also biochemistry, pharmaceuticals. We have computer scientists who are trained in chemically related computational issues. We have executives and managers, so our membership is pretty broad. I encourage you to think about joining the Chemical Consultants Network if you are not already a member, and if you have been a member in the past and haven't renewed, please do so. At this point, what we typically do is go around very quickly each table and ask for newcomers to introduce themselves very quickly. Everybody that I see here is familiar with CCN. Herbert, you want to say something very quickly about yourself?
Yeah, I'm still working towards hotel development division.
Your name, please?
My name is Herbert Chow. I'm planning to retire in June. Chemist by training. My career pretty much all working in all the polymer field.
Hello, Dennis Murphy. I've been in pharmaceuticals a great majority of my career. The thing that I enjoyed the most was lead on biochemistry. I recently took the retirement package instead of relocating to New Jersey, and so I'm exploring the last chapter, I think, of my career, using the consulting idea to work with a company in Boston to work on the hottest thing that I've seen, CRISPR technology. So that's my main scientific interest right now, is to go get my fingers wet in that, and have do some really interesting science for the last 2 years of my career.
This gentleman, you want to introduce yourself briefly?
I'm Joel Schertler, chemical engineering consultant. I was retired in 2014. My company decided I was too old. Been consulting ever since in chemical engineering. My specialization is process scale-up and process commercialization. I also do white papers, marketing studies, pretty much a jack of all trades. So happy to be here tonight. Thank you.
Good, thank you. Anybody else at the table? Oh,
Hi,
please.
Marcy Kwong. I'm currently employed probably for another decade, I would say. And I work at Merck. I'm actually in regulatory affairs, and I haven't done that much with vaccines compared to a lot of my colleagues who are at Merck, so that's why I was interested in the talk tonight.
Very good. Thanks for coming, Marcy. Anybody else at the table is not familiar with CCN? Anybody at this table? John, you want to say a few words?
Can I remain seated?
Sure.
Yes. Yeah, my name is John Oliver. After a career in manufacturing, I started my own consulting business about 20 years ago, primarily helping manufacturing companies across a broad range of industries. The reason I'm here tonight is I'm on the board of the Institute of Management Consultants, Greater Philadelphia chapter, and I do liaison with Mike, who's not here this evening, so that we introduce each other to our respective events in case there's a mutual interest. So I'm here just to find out who's doing what and maybe have a little value here and there.
Thank you very much.
I have one. The business side of consulting and agreements and such is completely new to me, and I realize I don't know at all what I'm doing in that. So if someone is interested in some mentorship and guidance along those areas, I'd love to hear from you.
Sure. No problem, Dennis.
Do you have a
This
business
group,
card on you?
Not right now. I'll come to the next one to the card.
this group indeed is the
If
place
you want to be in
come.
consulting,
Yeah, I need a
you-
business card.
You need something you can give out that allows people to communicate with you. It doesn't matter if it's the back of a napkin. You,
I have paper.
I think he has those on the way, and this is the right group to ask for that now.
yeah.
Okay.
Back to
Terrific.
explain about Bill will work too.
So, that's part of the character of our group as well. Okay, so today we're honored to have as our guest Dr. Dennis Gross as our speaker. Dennis is the CEO of the Pennsylvania Drug Discovery Institute. The mission of the PDDI is to provide service to the scientific community, such as workplace reentry assistance for displaced researchers in the pharma and biotech industry, networking activities, and support of entrepreneurship. Dennis is a professor at the Bloomberg Institute. He's on the faculty at Jefferson University and the Sidney Kimmel Medical College, the Geisinger Commonwealth Medical College, and Harrisburg University. Dennis got his PhD from UCLA, did a postdoc at Tulane Medical School with Professor James Fisher and Dr. Louis Ignaro, who was a 1998 Nobel laureate. Dennis joined Merck in 1977, retired in 2006 as a senior director working at a number of Merck sites in the US, UK, Italy, Canada, and Japan. Upon retiring from Merck, he joined Jefferson University as Associate Dean for the Graduate School and Associate Professor at Pharmacology and Experimental Therapeutics in the Medical School. And today we're honored to have Dr. Gross talk to us about the science and manufacture of vaccines, certainly a topical subject for all of us. Okay, Dennis? Here.
I want to thank you for inviting me back. You obviously didn't learn your lesson the first time, so I'm going to give it another try and see what happens. People are talking about retiring, and I've been trying for a number of years to retire. I haven't figured out how to do it. That's not a class you take in graduate school. It's how to gamble and how to retire. Maybe they're both the same thing, so I keep trying by trying different avenues, various ways of keeping my career going. So what we're going to talk about tonight is a little bit of an introduction. Keith and I were going back and forth for a while on what to present to you tonight. And part of it is sort of an educational mission. Vaccines have made a large presence in the marketplace, a large presence from a global health standpoint, and I'd like to talk a little bit about, as Marshall Sims used to call it, an educated consumer. Just be aware of what's happening and what some of the pressures are. So we talked a bit about that. And what Keith really wanted also was a little bit about basic immunology. How do the vaccines work? Why is this important? And what is it in our body that allows a vaccine to work? Or in some cases, not work? And we'll address some of those issues. And I'm a big fan of history. I'm a member of the History of Science Society, and just like Santiana said, if you don't study history, you're going to read it. And I think in this area of vaccines, we need to understand the history of how it started, where we are, how we got here, and how the technology has evolved to where it is today, because some of the technology is used in a lot of other areas. And then we'll talk about some manufacturing case studies. And, part of my backup here that I discovered tonight is I have my own personal Wikipedia, which not many of you do, but Bob Citron and I go back probably about 30 years. And I used to actually be the administrator for his area when he was in bioprocess manufacturing in West Point. We both worked at that site for many, many years. So if I make any mistakes, I'm relying on Bob because I'm actually using some of his slides, which he didn't realize. some of the articles that he wrote by a couple of other people. And we'll talk about futures. Because, as you've seen, if you watch the newspapers, you listen to news, especially if you don't go to the Fox News site, you look at some of the other things that are happening. We're dealing with a world in which there are a lot of emerging diseases. And I'm going to talk a little bit about how do we deal with some of these emerging diseases. What are some of the tactics? And Bob is going to be an excellent resource for you if you want to chat about that. These are the work he's doing with PAC organizations and some of his past experiences. So we're going to talk about this. One of the reasons why. Anybody remember SARS? Okay. For a lot of us, SARS was a real problem. I was working at Merck at the time, and we were doing work in Canada, and it was really difficult to get into Canada because Canada was a major hotbed for SARS. It originated, we think, probably in China, and a real interesting point of contention, the Chinese underreported the disease for many, many years, a significant number of deaths. SARS reared its head, became not quite, I guess it wasn't considered a pandemic, but it was an epidemic, and we haven't seen from it since 2004. Worldwide, and then it became a problem, and it disappeared. It was a problem in Eastern Canada, less of a problem in Western Canada. I was doing work in Vancouver. You flew into the Vancouver airport, it was like somebody had set off a neutron bomb. There was nobody in the airport. Nobody wanted to go to Canada. And in fact, in Toronto, they did what was called social distancing. They just told everybody, stay home. And Toronto lost about $2 to $3 billion Canadian in commerce because nobody was going to work, because everybody was so afraid of being able to catch the disease and transmit. There's no vaccine for this, and we still don't know exactly, other than the fact we know the coronavirus, where it originated from, other than China, and probably from some of the food markets in southern China. What we're living with now, measles. It's a huge problem. We almost thought that we had eliminated measles in the United States. I haven't happened anything to know that. I kept checking again this morning. CDC hasn't listed anything for the beginning of January up to this point. The last number I had was December 5th. That there were almost 1,300 cases of measles in the United States. It's the most cases since 1992. Here's an example of something we thought was almost eradicated in the States, and it's rearing its head again with the number of deaths. And the bulk of the cases are linked to an outbreak in New York City. A certain population of Hasidic Jews with a lot of concentration of people who are not getting vaccinated. With the cases of measles, goes mumps. During the holiday period, just before holidays, there was an outbreak of mumps at Lehigh University in Pennsylvania in the dormitories. You don't get vaccinated for measles, you're not getting vaccinated for mumps. These are not benign diseases, and we've lost sight of the value of vaccines in these areas. In the hotspots, Pennsylvania, Texas, Arizona, California, especially Texas, where there is not an awful lot of vaccinations. And Pennsylvania, Pittsburgh, Philadelphia, and Pennsylvania in between, where we don't have an awful lot of vaccinations. So it's a real problem. It's going to be a sea change, and that's the thing that we're dealing with. How many people remember, which is still fairly recent memory, the disease that caused this? Microcephaly?
Zika.
Zika, exactly. We know what the vector is. It's mosquitoes. My understanding is the disease originally originated in Africa, transmitted over to South America, and as we've dealt with warming, it has migrated up and present in the Florida area. There's a vaccine. I think Inovio has a vaccine that's been used, and it's still present. This is a big one. can't have any pictures of Ebola virus because of the fact that it's a hemorrhagic disease, leaves microorganisms in your body. It's a major issue. We still don't know what the vector is. People have talked about it in the World Health Organization. Is it bushmeat, barbecued monkeys? Is it rats? Some people think that it might possibly be bats. The problem is that you have countries separated by a river. Bats don't read the Rambin Valley Atlas. You have countries on one side of the river that has Ebola outbreaks, on the other side of the river that nobody has Ebola. It's become a problem. At the last meeting, 2 years ago at the bio meeting, there was a whole session from people doing the grand challenge for grants. And one of the things they were most worried about was priorities. Looking at these, yes, they're devastating. Somebody at the meeting asked, how many people contracted in that last round of Ebola that we had? The first one that came out. How many people died of Ebola? About 14,000 people. They asked the question, how many people died of malaria in the world that year? It's about 1.5 million people. A lot, mostly children. How many people died of tuberculosis? About 1.3 million people. Also, mostly children. But what's making the front page above the fold of the New York Times? The 13,000 people that died of Ebola, not the people that have died of tuberculosis. So you're always looking at 2 million people that die every year, and it's not making the newspapers, and not enough lot is being done in these areas where this is getting people incredibly torqued up, putting the barriers to people migrating back and forth because of the potential for having Ebola. So priorities are what's becoming a problem now for many people, looking at what vaccines do we develop, what are the incentives. And that's where people like the Gates Foundation come in, World Health Organization, Gavi, some of the others are trying to figure out other ways of getting into the space. So we're going to talk about this, and what I'm going to give you is my crash course in immunology. So you understand how these things are actually working. So my crash course is this. Print this out, go and look this all up on Wikipedia, and that's a crash course. It's everything you know about immunology. It's every term that you need to understand if you want to read a paper. Whether it's antigens, interferons, secondary, RH, this is it. That's all with immunology. So you can all hear it, cannoli, and go home. In reality, we need to understand a little bit about the entire process, what the immune system is, which is everything that mediates our resistance to infections. And in some cases, the body looks at foreign organs as an infection, or looks at cancer as an infection. It's a foreign substance. It's something that's not self. So you have the immune system, you look at immunology, which is the study of these structures and functions of the immune system. And then we have immunity, which is a resistance to pathogens and the toxic effects. And that's what the vaccines are being designed for, is to deal with these exogenous materials that get introduced into our body. And so our response is this coordinated response to these foreign substances, and it's mediated by components of the immune system. So we're starting at the top of what the system is, and this is what the response is about. That's what we're going to be going through in a couple of slides. And so you've got primary organs, where a lot of this happens, the red bone marrow, the thymus, near your thyroid, and the secondary lymphoid organs, the spleen, and your lymph nodes. You know, you really do have two circulatory systems in your body. You've got the cardiopulmonary system, which is, you know, a loop. You have blood leaving your heart, going to the lungs, back to the periphery, back to the heart. You have the lymphatic system involving the lymph nodes. That's a one-way circulatory system. From the body back through the heart, through the lymphatic system. But the heart isn't pumping lymphatic fluid back in the circuit. And a lot of what goes on in the lymphatic system involves the lymph nodes and its primary and secondary lymphoid organs. Picture of my friend here, you can see where all these organs are. The thymus, very near the thyroid. If you've ever traveled in Europe, especially in France, you order something called sweetbreads, that's what you're eating. You're eating the thymus gland. Young cows is where you get thymus from. But these are all the tissues that generate the components of the cells in your body that respond to exogenous materials. And sometimes endogenous materials. The spleen, the lymph nodes, which are present on the lymphatic vessels, the thymus, and then the bone marrow, which is producing not just the red cells and the monocytes, but also the lymphocytes that end up having to deal with exogenous materials. So the thymus, has a lot of this, and that's where a lot of these cells originate that can become part of our immune system. It's from the thymus gland and the bone marrow, the lymphocytes, the monocytes, the eosinophils, the basophils. These are all the white blood cells that are part of how we respond to exogenous materials and to infections, along with the red blood cells, the reticulocytes, which give rise to red cells, and the platelets, which are actually involved in clotting mechanism. On the good side, they can also be involved in clotting mechanism that leads to clots, heart attacks, cardiovascular events. What's interesting, though, is as we mature, where some of these cells come from changes, especially in the bone marrow. In children, almost every bone in the body contains a red bone marrow that produces all those white blood cells. As we get older, it turns out to only be the skull. Nobody's going to actually tap your skull if they need to get a bone marrow sample. It's a little hard. If you miss and go too far, obviously you're running somebody's brain. You don't want to do that. Ribs are hard to get from stirring. So in most cases, when somebody's doing a bone marrow sample, you're going into the pelvic bones, going into the back, the iliac crest. It's not a trivial procedure. I should have brought it with me. I have one in my office. I have a bone marrow aspiration unit that somebody bent on a patient I was working with when I was at Tulane Med School. They did a really hard portion of the iliac crest and bent a needle, which is really a trocar. It's a hollow needle with a tip on it that looks like a nail. You drive in a little silver hammer, and then you go into the bone, and then you pull out this nail, and then you can actually aspirate the bone. If you don't do it right, you can peel your patient off of the ceiling. It's not pretty. So being a bone marrow donor is not a trivial process. But as you get older, where you generate these cells changes. Your immune system changes. Your responsiveness changes. So if you've seen what's been going on lately with influenza, there is a version of the flu vaccine for us as slightly more mature people because our immune system isn't as effective and responsive as it was to say 20 or 30 years old. It's because of where all these cells are being generated. They change over the years. So what we're looking at is really two different kinds of responses. People call innate responses, which invertebrates and vertebrates have, and then adaptive or acquired immunity, which is where vaccines come in. And that's what only vertebrates have. All invertebrates, vertebrates have innate immunity. It's an immediate response. You cut yourself, you get dirt in, you're working in the garden, and you get a response immediately. Cells rush that area to try to deal with whatever's present in the dirt someplace. There's no antigen contact, and the important thing for people designing vaccines is this issue of memory. You cut yourself, and the bacteria are really approached by phagocytes. There's no memory involved. You have it, and your body responds within a couple of hours. We'll talk about what happens with that. It's something that what you're trying to do with the vaccine is develop a memory. So you get vaccinated for polio, you get vaccinated probably once in your life, unless you really want to be risky and try to get another challenge to see if it may work or not. But we'll talk about that because what we have is the ability to have innate immunity. You have a barrier, your skin, lining your pulmonary tree. That invisible barrier is a barrier that keeps the outside outside. You cut yourself in the garden, those cells get inside the body. Phagocytes will actually go in a very brief period of time, over say 12 hours, and phagocytize those bacteria and destroy them. Or a complement will help you with that. But on the other case, you have adaptive immunity. This is the one we're going to be talking about again. This is involved with the vaccines. The vaccines that Bob Citron expansion in his life at Merck, HPV, some of the other vaccines. Because there you're dealing with lymphocytes, you're dealing with humoral response, which is beta lymphocytes that produce antibodies that can bind to this exogenous material, or cellular, in which you have these T lymphocytes that produce effector cells that belong onto this material and destroy them also. But the timeline is what's different. You're talking about days, sometimes perhaps even weeks, to get a response. So if you don't go in and get a flu vaccine, and the next day you're protected against this severe strain of influenza, or 3 strains plus the avian flu. Because it takes a while for this adaptive or acquired immunity to build up in your body. And you'll see what you're looking at is the fact that the immunity is your ability to remove these pathogens. Innate immunity is fully functional without any previous exposure. Your body knows. You get cut, you're in the garden, you get dirt in it, your body knows how to respond. You get a sunburn, your body knows how to respond to a sunburn, or a chemical burn, or an electrical burn. You get an inflammatory response. You didn't have to tell it how to do it, it doesn't. The adaptive immunity is dependent on your exposure to something very specific, to an antigen, a molecule that stimulates an immune response. So that's something you need to distinguish between adaptive or acquired immunity and innate immunity. This your body knows what to do. If you're a starfish and you're an invertebrate, it knows how to respond to an insult immediately. It knows what to do. Pull back, try to heal the wound. Adaptive immunity, you have to train the body. That's what we're talking about. So innate immunity is born. It's your first line of defense. You get exposed to something exogenous. You have physical barriers, your skin, lining your esophagus, lining your airways, macrophages, NK cells, antigen-presenting cells, soluble mediators that complement. These are all things that you need to think about as mediators of this innate, built-in immunity that you're born with. The chemical barriers, your skin, mucous membranes, your nose, those are all important areas. Upper respiratory, cilia, that remove mucus and trap particles. Remember when I was in graduate school, we had somebody who was actually looking at cigarette smoke and finding out that cigarette smoke actually paralyzes the cilia in your trachea. So you don't move that crap out of your lungs rapidly, your esophagus and the particles. So that's one of the consequences of smoking is that you're eliminating the protective mechanism for innate exposure to materials. By paralyzing the cilia, which are always beating, and now you put something on them and prevent them from doing what they're supposed to be doing as part of this innate mechanism. What glands on your skin? They're actually there to certain chemicals that we can control some of the bacteria. Again, it's innate. They're present all the time on the surface of your skin. And then your stomach acid, and then the normal bacteria. These areas are getting very hot. You can follow what's been going on with the microbiome. You know, it's a really hot area of research. There's even linkages now. People are starting to talk about maybe the microbiome and Alzheimer's disease, and some pathways involving the vagus nerve transmitting back into the brain via the microbiome. So that may be a very interesting area to try to think about. Is this part of our ability to determine self versus non-self and dealing with the genesis of diseases? So this is a physical barrier. You have inflammation. You get damage to tissue. Sunburn. I grew up in Los Angeles. When I grew up in Los Angeles, people didn't have sunblock. There weren't many sunscreens other than zinc. And what, you know, those are badger curves. At the end of the summer, how many sunburns and how many times did you peel? You know, that was the badger curves. At the end of every week, you had a bright red back or a burnt forehead, and the only thing you ever did was you put cocoa butter. So everybody walked around smelling like a Hershey bar. You know, that was your solution to getting a sunburn. Walking around smelling like that Hershey bar. So, but that skin damage produces an immediate inflammatory response. And the idea, even if it's a chemical burn, is you try to reduce exposure to the infection or to the burn, but increase exposure to your immune system. You try to wall it off so that your natural killer cells, your natural ways of fighting these infections, and you'll see this by redness, heat, swelling, and pain. That's your way of responding innately. Nobody needed to train you. You get burned with a chemical burn in the lab, and an immediate inflammatory response. And you see swelling, you get some pain, obviously, something like that. And they persist. And when it persists for a long period of time, then it becomes harmful. Then you got to start worrying because it gets walled off with it's a case of infection. You may end up getting an abscess. And that's the taken care of. So, talk a little bit about innate. Let's talk about the adaptive. Because that's the one that vaccines are targeting. Because you're dealing with something that's going to take days or weeks to be able to produce that response. Sometimes it may take a month, maybe even longer. Look at some of the vaccine schedules these days where you may go over many, many months of repeated doses until you actually achieve the right level of neutralizing antibodies. And prior contact and its memory is very important. So we're dealing with antigens, something that the body defines as foreign, and it mounts an immune response to that. Most of these things are proteins, some are glycoproteins, some are nucleoproteins, and polysaccharides, sugars. These large proteins have several epitopes. So this is what you're dealing with, because you're trying to produce something that responds to that exogenous antigen. And that's what the vaccine is trying to do. And what ends up happening is you produce antibodies to those, and they're specific. We have a catalog of probably innately, we probably have 500-600 of our own circulating antibodies to antigens that are out there that nobody has to vaccinate us for. Just think on a daily basis, you're making more and more of these spontaneously in response to our environment. And they work. They bind to the antigen. Adaptive immunity doesn't necessarily react to your own cells, and it's part of what you see this all the time now when we talk about transplants. Is that we're trying to talk about the distinction between self and non-self. And the immune system is very good. So you see one of the consequences of something like a heart transplant or a liver transplant or a lung transplant is having to suppress this entire system. Like a drug like FK506, taclomas, the original fucosamide drug, or high doses of steroids to be able to try to calm that down. Or dealing with the fact that you may have some autoimmune disease where the body just turns on itself. Lupus, as an example. So it usually takes 5 to 7 days to be fully activated with adaptive immunity. And hopefully what you hope with the vaccine is that this immunity lasts for years. We're all old enough, we've been vaccinated for smallpox. So we all hope that smallpox vaccination is going to last for the rest of our lives. And I don't know if anybody wants to be challenged on it to see if it's really working, but I have one of my slides. There are actually 11 substances in clinical development now for smallpox, either antivirals or small molecules. So there are still some startups that think that smallpox is still a potential target to biological warfare, so that people are still working. We were supposed to work on that for a while. West Point, a lot when I was still there. Beta cells that produce the antibodies and then neutralizing antibodies. And as part of the clinical trials, this is what many people, that's part of what Bob's laboratory did at West Point, was look for these things to find out, is that vaccine really working? You know, you all dealt with probably small molecules. What do we do? 5,000, maybe 10,000 patients in a phase 3 clinical trial. Merck did Zostavax, which was for their their chickenpox vaccine.
Shingles.
It's a higher dose for shingles. 70,000 patients in that trial. Rotavax was 68,000 patients. So very large number of patients because of the vagaries of the immune system, the vagaries of the response, and knowing how long does the product last, how long do you get that kind of immunity, where does it reach the point where you are sure that you have a reasonable number of neutralizing antibodies that might protect you, and when do you start getting waning and loss of that memory. So we have the T cells that are involved with helper T cells that stimulate and release cytokines. That could be a good, it can also be a bad. I remember a couple of years ago, there was a company called Nigiro, it was a German company. They had a compound that produced what was called a cytokine storm. And it was done at Hammersmith Hospital in the UK. And they made a critical error in doing a clinical trial, a phase 1 trial in 6 patients, because they gave the same drug to the same 6 patients at the exact same time. And they had a cytokine storm. And a couple of patients almost died. They had gangrene. Some of them lost fingers, toes in this process because the cytokines were released in a massive dose. So sometimes these helper T cells help, and sometimes they don't help. Coming out of business. So what is a vaccine? Preparation of microorganisms, bacteria, virus. You're producing something that gives you an immune response with memory. You get either a humoral antibody response or a cellular cytotoxic or killer T cell response to a pathogen or a pathogen-infected cell. And what you're trying to do is prime your body so that you get a secondary immune response. So if you see whether it's we'll see a small particle that looks like your virus, or an inactivated particle, or a whole virus that has been attenuated, the body sees it, gets ready so that when it sees the real thing, you are exposed to pneumonia, you're exposed to perhaps polio, or hepatitis B, or hepatitis A. The body has seen something that says, I've seen this before, and now I'm going to mount an immune response to the real thing. And that's that catalog of antibodies that people are making up for future exposure. So the big thing here is memory. We're not talking about the song in Cats. This is what is really important, is having the body develop that memory, which we hope will last for years and years, but may require multiple boostings also, to be able to keep your system active. So this is from actually from the CDC about why you do this sort of thing. Is the first exposure, you get these titers that rise. The second exposure gets a little bit higher, depending upon the vaccine. I think our hepatitis B vaccine, it took about 3 doses to get up to the right titers. Our Hep A vaccine, about 3 doses. GSK's took 2 doses, because there's, I think, that extent was a little bit dirtier. And you get to a level where you decide, at some point, this is going to be providing adequate protection. What we don't do in many cases, unless you're in a particular field, is we don't go back and retire these patients to find out, does this stay stable? Because there are still patients out there who have some issues. I'm a hyporesponder. I've been vaccinated 3 times with the plasma vaccine for hepatitis B, and 3 times for Combavax, and 3 times for rabies, because I don't hold titers. AB vaccine were not bad. I can tell you the rabies vaccine is not one you want to take. But when you work with unconditioned mongrels, you get vaccinated for rabies. At least that was Merck's policy. So, because you wane. And so you need to go back and find out. We went through this with our chickenpox vaccine. Varivax is one of the, I think one of the constraints was it 10,000 kids for 10 years to find out when do you see what's called breakthrough? When does this fall down to the point where you aren't protecting the kids anymore? And you don't have adequate immunity in the population. You've got to go back and boost them again. So that's what involves 70,000 kids, or adults and kids, and takes place over many, many years. It's trying to understand how do we do this? How do you keep track of those patients and go through this entire process? So basically what you're trying to do is establish memory. Now, memory is great. It's wonderful if we're developing a vaccine and you're trying to create memory in the body that's going to respond when you see the real thing. But as I said, memory is a two-edged sword. If you're now doing gene therapy, which is not the topic of this talk, and you're using adenovirus-associated vectors to deliver, the jewel box and you're delivering your vector via this vector. There are, 153 serotypes for the common cold for rhinovirus, maybe the same number for adenovirus. One of the issues right now with gene therapy is that we have to go back in. You've established a memory for that vector, that serotype. What happens in 5 years if Lux turnip has to be reboosted again? Somebody has to see that gene therapy product. You will have to probably have another serotype of this material. So here's where memory is not what you want, and if it's in a vaccine, that's what you want, memory. So this is one of the long-term consequences of dealing with these new areas of the immune system. So let's take a look at the vaccines. These are all the types of vaccines that are out there that people have been talking about, that people are developing. These are the ones that we're going to talk about tonight a little bit with some production material, MMR, which is drugs, measles, mumps, and rubella, rotavirus vaccine. These are different types. Attenuated vaccines, killed or inactivated, like inactivated poliovirus, hepatitis, or the influenza vaccine. The old ones, diphtheria, tetanus, and then the subunit vaccines like HPV, Gardasil, Shingrix, hepatitis B, acellular pertussis. These are the vaccines that you're probably most familiar with, that we've all been vaccinated for, or at least most of these have been vaccines that we've been vaccinated for over the past couple of years. And this is a chart, Bob and I were just talking about this before, that was actually produced by Morris Hillman, who worked for Merck for I don't know how many years. Died in 2005. Morris worked up until 2 weeks before he died of pancreatic cancer. And he developed at least 40 vaccines in his tenure at Merck. And there's a wonderful book on it. It's a biography written by Paul Offit called Vaccinated. And they just made a movie about a year ago on his entire life, how he approached developing vaccines. But you can see, most of these vaccines were developed by Morris Hillman, working at the Merck Research Laboratories. But the whole history of this enterprise is really in 5 people, none of whom won the Nobel Prize for products that have impacted billions of lives worldwide over an awful lot of years. Starting with Edward Jenner, we always talk about Jenner-style vaccines back in the late 1700s. Louis Pasteur, in an era before Iacooks and IRBs. The anecdotal story is that some woman's kid was bitten by a rabid dog on the streets of Paris, and the woman raced into his office and said, "Professor Pasteur, I heard you're working on a vaccine for rabies." And he said, "Yeah, roll the kid's sleeve up," and he gave him his vaccine. Right there. And he didn't get rabies. But some of the others, Salk, talk about that. Albert Sabin with his oral vaccine for polio, and then almost all the other vaccines that Morris Hillman developed over the years. It's an amazing track record, and that's what I want to do, is talk just a little bit, because I think history is important to understand, because as you'll see, as we move through and you'll see some of Bob's slides, the process has gotten much more sophisticated, much more time consuming, which is becoming a barrier to entry when you try to think about how do we deal with these emerging diseases. If you're trying to develop a vaccine to SARS or MERS, Middle Eastern Respiratory Syndrome, which originated in camels in Saudi Arabia. How do you come up with a vaccine when you see some of these processes? So this is the way people thought that they could protect themselves from cholera. Wear shoes, get yourself off the ground, wear a mask, protect yourself from bad vapors. And this is from the Burroughs Wellcome Collection. People actually thought that this would protect you long before the idea of vaccines came out. So the first one that really anybody used was for smallpox. And it was developed by Jenner in the late 1700s. People used to have vaccination parties, and they really thought that everybody was going to go crazy from getting vaccinated. But this was non-vaccinated, they're non-purification material. This is what somebody looks like who actually had smallpox. Smallpox was used as a weapon. Bodies, we killed an awful lot of Native Americans by throwing blankets from patients, from soldiers who had smallpox, giving them to Indians and killing them. All the way back to the time of Genghis Khan, they would throw bodies over the walls of people who had died of smallpox and killed off the entire population in walled cities. But we also have a very Western-centric attitude towards where these discoveries came from. So we think that, Jenner invented smallpox vaccination. In fact, the Chinese were doing it in the 1600s, long before Jenner was dealing with it. The Chinese also invented movable type, and they made paper money long before anybody in the West ever made paper money. As I said, there are 11 substances now developed for antivirals or vaccines for smallpox. There are only 2, I think, still repositories for smallpox. One's in Russia, and the CDC somewhere around the Atlantic has the second supply of smallpox. Was it every 2 or 3 years they get together and decide we're going to destroy the samples, and people from academics say, no, we still need it because somebody might be using it for biological weapon of mass destruction, so we need the original material. So it keeps getting, I've seen pictures once of the Russian facility. It looked like a pool shed with a bicycle lock on it and a guy standing outside with a Kalashnikov. It doesn't give me a warm, fuzzy feeling about the other supply being guarded appropriately, but this is one way, and this is the beginnings of the vaccination process. But fast forward, and a lot of these things happen because of wars. So, whooping cough, pertussis. The first vaccine was licensed in the United States in 1914. This is from a book by John Adams and Emily, two of our colleagues at Merck, biomedical engineering. It was a wholesale product. It was combined with DTP, so you had diphtheria, tetanus, and pertussis. It led to a lot of side effects over the years, so people went to develop an acellular form. You've seen the ads on television. I don't know, maybe it's Pfizer that still has the ads for this woman, a grandma holding a child and morphs into a wolf, saying, get revaccinated. Because what's turned out is this cellular form has not been as effective as the old form. My son got whooping cough about 10 years ago. His 30th birthday, he got a case of whooping cough. He was told to go back and get revaccinated. Because the vaccine turned out to be not as effective. At least the lots being produced in that time period didn't work as well as the old material. But the process is getting a little bit more sophisticated. There's purification involved. There's centrifugation. There's inactivation, formulation of formaldehyde, thimerosal, and then absorption with an aluminum adjuvant. So this is what's out there today. Switch to polio. We think of it as a modern disease, 40s and 50s. There's evidence of people with polio back in Egypt in the stele from 1400 BC. It's obviously somebody has polio. They're also using a cane. So it's been around for a long time. Bob and I were just talking about this. AIDS Foundation is making heroic efforts to try to eliminate polio worldwide, but it's running into significant problems. The vaccination teams in Pakistan are being assassinated by the Taliban. It's not getting much uptake in some of the sub-Saharan countries. Afghanistan has problems. Gates has been trying for years to finish vaccinating people in India. It's a problem being able to distribute a vaccine that has to be kept cold and getting people to accept it. And there's just an awful lot of pushback, thinking that this vaccine is going to sterilize people. So it's a problem. So here's a fairly recent photograph of somebody with polio. People don't remember covers on Life magazine. Remember Life? And people sitting, kids and adults in iron lungs. That was the consequence. Absolute panic time in the 1950s. When these vaccines first came out. And people were not allowed to go to swimming holes. You couldn't get gatherings together. People wouldn't get together because we know how polio was being transmitted in those days. Jonas Salk, who's the University of Pittsburgh, came up with a way of making it really simple using monkey kidney cells. Through this inactivated polio vaccine, centrifuged it down, formula inactivated. He was so sure that his vaccine worked that he inoculated his entire laboratory and his family and then exposed them to polio. Work. And he never got the Nobel Prize for this investigation and this invention. But it turned into be a little bit of a problem because it was injectables. So if you go back and look at the old history books in that time period, even some of the medical microbiology, you can't line up a bunch of people, you can't get enough needles. So the Army invented this air gun that would shoot it through your skin under high pressure, and it stung like hell too. It was almost as bad as getting the injection, but that's how people were getting the injection. Until Edward Saban came up with this oral form, which is a live virus, and you could put it on a sugar cube. Ultrafiltration, and you were able to produce the material. There was a third person that most people forget about, Hillary Kaprosky. Hillary was at the Wistar Institute in Philadelphia. He developed a polio vaccine. He did the bulk of his work in Africa. Hillary Kaprosky was blamed by Rolling Stone magazine for starting the AIDS epidemic because he used chimpanzee kidney cells, and they claimed that the chimpanzee kidney cells were in his polio vaccine, and that he started the AIDS crisis by injecting his kidney cell-generated vaccine into people, and they developed AIDS, or polio as a consequence, and then he transmitted that into people, which then came into the United States. So he's claimed. Somebody at Wistar actually found some of his vaccine a couple years ago. Looked at, there's no HIV vaccine in his stocks from back in the 50s, but Rolling Stone never retracted the article. Hillary died about 3 years ago. He left Wistar and went to Jefferson for a number of years, running a laboratory there, trying to come up with novel ways of administering vaccines in developing nations. One of his things was trying to put the constructs for vaccines into bananas. So if you ate a banana, you dosed yourself. And it was stable at room temperature. You didn't need a -20 freezer to do it. People forget it. But there was such panic in the United States over having enough material that what ended up happening was the government parsed this out to lots of companies. And this is a book written by Paul Author, who's head of formulary at Children's Hospital in Philadelphia. You heard some of his books, are fantastic. And Cutter Labs was a dispensing pharmacy in Oakland, California. They had never made a vaccine before, but they applied for the grant and they got the money from the government to be able to supply vaccine. They didn't, because they hadn't done it before, they did not follow SOX production protocols. And they shipped out vaccine with live virus in it. 40,000 kids became ill with polio. 200 became permanently paralyzed. Some of their parents became sick from the polio, and 10 kids died as a consequence. So that's why it was called the Cutter incident. So as a consequence of that, what came up was the neurotoxicity test that's used for live and attenuated vaccines. We used it for our chickenpox vaccine, Varivax, putting it into monkeys to find out that the material can actually grow in the CNS tissue. These vaccines weren't sensitive enough. So hepatitis B, Bob and I were just talking about this. Everybody's excited, and rightfully so, about Gardasil and the Cervarix, the vaccine from GSK, for human papillomavirus as a vaccine to prevent cervical cancer. Hepatitis B vaccines from the 80s is a vaccine that prevents liver cancer. The Merck material and the GSK material, because fulminating hepatitis B ultimately might lead to liver cancer. Forget that. We've been vaccinating folks for a long time to prevent liver cancer as a consequence of getting a full-blown hepatitis B infection. You get it, you know. Jaundice, loss of appetite, joint pain. But again, the reason I bring this up, and this is from one of Bob's books, an article in Clinical Practice with Ron Ellis, a number of years ago, 1993. But the process has gotten much more sophisticated. That's why this is not the sort of thing where you buy a little bit of equipment, put it in your basement like people have been doing for years, making counterfeit drugs or fake drugs. You need a lot of technology to do this. You need the back end, the downstream processing and testing. The things at Bob's Labs, they sell that, they can make what you thought you made, and is it safe to be able to go into people? Going through all of these steps, filtration, homogenization, fermentation, all the chromatography, getting rid of all these things. When we made our plasma-based hepatitis B vaccine, I think that took 14 months, and something like 50 or 60 inactivation steps, just to make sure that what you had was a safe vaccine based on plasma. So, you know, this is all really important because it's non-trivial technology. You're chemists, some biochemists. You know, and you do chromatography. But the chromatography that people do when they make these things is of a different scale. You know, we're talking about having to filter maybe 20 or 30,000 liters of material. Turns out there's only about one company, there's a monopoly in some of the resins. General Electric owns 80% of the resins in the world. And I think there's only about 4 or 5 runs you can do on a column like this, then you got to dump it. So just think of putting all those pounds of resin into these stainless steel chromatography columns. The floor loading is immense. You build special buildings to do this sort of thing. Same thing with centrifugation. You know, a lot of centrifugation on the commercial side got started because people needed to separate cream from milk. This is actually an ad from Alpha Laval. That's how they got started, was making centrifuges to separate cream from milk. And that came up with this thing called the Sharples centrifuge. I think we still have a couple at West Point. They were air-driven. They ran in a big walk-in refrigerator, and they had a significant problem. They had a tendency to blow up. So, you know, you didn't keep them around for too long, or if you did, it was like, remember the old autoclaves that you had to manually valve? You valved it and you ran. You know, you hope you did it right, closed the door, and then came back like we had one of those 16 all the way to the end. You hope that it worked properly. It was either that, or you would have to disrupt too much asbestos on the valves to be able to really make sure you did it properly. But this whole thing matured because of the atomic bomb, surprisingly enough. 2 main laboratories. Manhattan Project. Hanford in Washington, which glows at night because of contamination, and Oak Ridge. One developed gaseous diffusion to separate U-235 and U-238, which was really a corrosive gas. It didn't lead to an awful lot of what they needed. The other was by centrifugation. So the excitement that everybody's having about the Iranians ramping up all their centrifuges, that technology was developed during World War II at Oak Ridge. separate the isotopes under centrifugation. We're not talking about the centrifuge that you guys use in the laboratory. We're talking about centrifuges that generate 1.5 million gravity, not 30,000 Gs. So when Oak Ridge finished up, they had all this technology. They weren't making that many more bombs at that time because they had a good stockpile. Someone said, we got all this technology, what do we do with it? So Union Carbide, which ran Oak Ridge and part of Hanford, said, let's get a grant. So they got a grant from the government. It was called the MAN program, Molecular Anatomy. And they figured, we know how to make these centrifuges. Let's start looking at molecular biology. We can separate the isotopes. Why can't we pull apart the components of the cell? So Norman G. Anderson and his staff created an entire enterprise around centrifugation. Low speed all the way up to the centrifuge that ran so high you could pull apart DNA and separate out the various strands of DNA based on density or size, spectral units. And that's what ended up happening, was a generation of things like electronucleonics called for centrifuge. It happens to actually be in this metal case because they also blow up. So this was a way of keeping track of this thing before it blew up. Or these newer ones, which you can actually reel into a process room. And they're all continuous flow. So you can go in and run a 5,000 liter bag through this and in the process, clean things up, pull out what you want. Electronucleonics has this set up so that you can actually, depending upon the length of the centrifugation pad, they'll tell you, I need to isolate this particular virus, you use this kind of rotor. If I need to isolate this kind of virus, I have a higher rotor because the input comes here closer to the wall so the G-forces are higher. This is interesting because electronucleonics developed this technology using government documents as we're selling it for a number of years. And all the government, back then it was called the AEC, Atomic Energy Commission, somebody suddenly saw an ad for one of these centrifuges and said, oh, holy shit. These people are selling a piece of equipment which you can separate the isotopes of uranium. That's illegal. So they shut electronucleonics down. And they said, wait, you can't put us out of business. I don't care about what the law says. You didn't tell us about that. These were publicly available documents saying, let them go back in, but these are speed limited. So you can't separate the isotopes of uranium. You can't separate viruses and pull cells apart. And you can buy these today and put them in your laboratory. You really want very high speed capabilities. So that's what happened there. So let's finish up on this source with influenza, which is out of these days, right? We're still using a technology that's 40, 50 years old. Growing in eggs, you find a candidate vaccine, you grow with the candidate vaccines in eggs, you incubate them for a couple of days, you inject them into fertilized eggs. At the end of this process, you end up with a vaccine that has 3 components and a 4th, avian flu or something else. The problem is trying to predict which strains to use, and the fact that this is a seasonal disease. So we're in the middle of our flu season now. Most of the consensus is a lot of influenza originates in southern China, which is all year round. We try to look at sentinel countries like Australia, where their winter is April and November, except this year with all the fires and temperatures of 100 degrees down there, and then try to predict what's happening from here as it migrates to the south and then comes back into the north. So it's really hard to try and stage all of these things. Try to put you in a position to be able to try to predict which strains are there. That's why some epidemiologists call influenza an emerging disease, because every year we get 3 different strains and hope that they pick right. And things don't mutate. So lots of eggs. Remember a couple of years ago, I forget when it was, there was a shortage. You couldn't get Egg McMuffins because there was a huge outbreak of avian flu, and eggs became a national resource. The facility for, I think it's Sanofi, has their facility in Swiftwater on the Poconos. Chain link fence, barbed wire, guys with armed guards, with bulbs and everything else around it, because it's strategic material making these vaccines for influenza. And when there was this avian flu outbreak, eggs were important for this. You didn't get an Egg McMuffin, but you sure got your flu vaccine that year. We used to have hen houses at West Point. We used to call them chicken Hiltons. You know, to be able to separate the birds from each other so that you didn't contaminate it. If you lost one flock, you didn't contaminate the others. So we actually had a labor issue back in 1984 at the West Point site. And a bunch of us worked I worked on on bear monkeys. I did the monkey consistency law testing in cynomolgus monkeys for 7 months, 7 days a week, starting at 4 a.m. in the morning until 8, taking care of these monkeys. And at that stage, because all the unit people were off site, if it didn't move, it got painted. And so we painted a lot of the chicken Hiltons. dress them up with nice colors, we put spirals on the manure processors, you know, just make everything look nice because I find a lot of paint who use this and really cleaned up things. But this is the issue. You can make 100 million doses a year, fairly compact, it's only 140,000. The guy I got this from claims no bioreactors, but you know what? Every egg is a miniature bioreactor. You're growing a virus in a little bioreactor, and you're using 600,000 a day. Think of how many egg McMuffins that is. You want to use that as a metric. And $150 million and they moved on an existing site. The problem is, it's been very, very, I have not seen data on this year's efficacy for the flu vaccine. I've heard that it's not that wonderful this year because the virus mutated during the production process. But 2018 to 2019, there were 2 waves of flu. The problem here is that it didn't mutate in production. The virus mutated in the natural state. So it was only about 47% effective, which is sort of about average the past couple of years, except for 2015. What ended up happening was there's a second wave of influenza with strains that were not predicted. So the flu vaccine was not that particularly effective. But this is always a crapshoot. Companies who make the flu vaccine. You make it, the government's purchase it, you make it based on the fact we think we're going to have X number of cases of flu, and there can be X number of, Y number of vials distributed. And if it doesn't turn out to be as bad as you think it is, Novartis, Sanofi are all stuck with vaccine that they can't do anything with, and you can't reuse it for the next year. So it's a real financial risk for these companies that are getting into this space. CSL, Commonwealth Serum Labs, has a company in Holly Springs, North Carolina. They're using canine kidney cells. They have money. The FDA looked at it, and HHS, they thought it was a really interesting process. They put $700 million into it. They can make it for half the cost. This was a number I got in 2016. It was approved. I don't know how much is sold, this year, but it was substantial. Because one of the drivers for this is it takes 8 to 9 months to make a standard flu vaccine. They can get out in 6 months. Again, what they're looking at is what's the next disease coming out there, which we need to respond rapidly. If it takes you 8 or 9 months, that's not rapid. 6 months is still not rapid, but that gets close. So protein science has been looking at caterpillars. Unfortunately, the cost is much higher. They can breed caterpillars, and it's a lot easier. No one wants to eat dry caterpillars. It's not like an egg McMuffin. And they can make 5 million doses, but they don't expect to sell that many. Because again, this is also an area where people are very hesitant to change. Figuring out, new vehicles, new source of material, isn't as antigenic as it was in the past. So this is one of the issues. So Novartis spent about $600 million making their kidney cell facility, same amount of space, half the doses for 4 times the cost. Be able to work with canine kidney cells. Novavax is working at the insect culture facility. It's a cheaper space, and they're up to almost the same number of doses. But it's a matter here of getting acceptance, getting physicians, getting the FDA, CDC to be able to accept the vaccine made something that's non-traditional route. Because there's also work going on down in Austin, Texas, using tobacco plants. It's another source for being able to grow these materials. So going from our state-of-the-art basic research laboratories up to where we're doing an awful lot of really good scale up in this modern 21st century laboratory, it's interesting to think about how you make these things. In some of the labs use roller bottles, these tabletop systems, move to these wave tanks, which just look like really nice big water beds. The advantage of these things is they're really interesting, they work well, but again, floor loading. We need to think about what kind of building can I put this into? The water weighs a lot. The equipment weighs a lot. This thing's moving back and forth. What's the structure you're building? You need to think of purpose-built buildings, and that's one of the issues. Because the processes are non-trivial. This is from a company that makes a software package that lets you take what Bob would do in his laboratory, writes in his lab notebook, and says, okay, this step's got to follow this step. You go into this computer program, and it lets you create the entire process in the computer. You can go in and say, okay, I have a chromatography step. What's the flow going to be like? I have centrifugation. How much water do I need? If I have to do clean in place, how much steam do I need? How much water do I need first? How much then steam do I need? How many people need to operate? It lets you size the entire operation, because over the years, one of the things that the FDA became very, very concerned about is cleanliness and quality and validating the entire process. And there's so few people at the FDA, there's only 17,000 people at the FDA. They said, you know what, we can't be everywhere at this time. You've got to assess some of these things and look at the quality and the process that you're going through and how well it's going to actually function. So doing things like this and assessing risk and managing risk become very important. So if you can put the process together in paper or in a computer and look at what does it take to run it, It even helps you decide, can I put it in my factory? Can this really go in Springhouse, or do I need to go and build a new site someplace? Or I don't have the capacity. I'm going to go to Lawson, New Hampshire, or I'm going to go to Singapore and do this where somebody has the capability to build a purpose-built factory for me or build it myself. So these are all really critical things of letting you look at the entire process and also assess the risk. If I have to transfer material from here down to here, where does that have to be? Do I need walls around the facility? How am I going to sample? Because when you start designing some of these facilities like this, you're talking maybe $3,000 to $4,000 a square foot to make a GMP level facility, to make a vaccine or a mAb. This happens to be the mAb facility for Amgen in Rhode Island when they were making their cholesterol-lowering drug, Repatha. That's their facility. They built the entire facility at risk, hoping they were going to get approved from the FDA for the product. Just think what happened, they didn't get approval. That's a lot of stainless steel sitting in the aisle while they go and argue with the FDA over, I'm going to get my product approved. So this takes time. It takes time to design it. It takes time for the company who's making your factory to put this together. This runs under GMP, which means you need to do FAT, factory acceptance testing. So they've got to assemble the entire thing at their factory. You have to run it at their factory, then dismantle it, ship it to your site, and then do IQ, OQ, PQ, which can take you another couple of years, and then do test runs and make sure that it's doing what you think it's going to do before you actually start producing product. So that's a big nut to crack. That's what makes it really difficult to think about, how do I respond quickly if something happens? Think about the size of some of these things. Think about the floor loading. $3,000 to $4,000 a square foot to make this kind of facility. So one of the things that people are looking at is thinking about, how do we respond to the next disease? I pulled this down this morning, yesterday actually. There's an outbreak of something, of a kind of pneumonia that's never been seen before in China, where a lot of these diseases originate from. It's happening in Wuhan, which is right on the Yangtze. Beautiful city, if you've ever been there. Great museum. They've had 59 cases. As of this morning, I had lunch with somebody today from GSK who comes from Wuhan. He was going to visit his family for the Chinese New Year. He decided against it because the outbreak has now gotten to 100 cases. And he's afraid that if he goes there, he might not be able to get back in the United States because it could be like SARS, and he could be blocked at the border, leaving the country or trying to get back into the United States. And all they know is it's a viral pneumonia. It's not SARS, it's not MERS, it's not MERS. They have no idea, and their perception from talking to his family is they have drastically underestimated the severity of this, and they really don't know what the cause is. They think it came from a seafood market somewhere in Wuhan, and it's now branching out and carrying out the cities of China. It sounds like SARS all over again, but it isn't a coronavirus. They don't know what it is. That's very worrisome. Here's an emerging disease. So if you want to get really worried, this is from December 2015, World Health Organization. These are all the either emerging or re-emerging infectious diseases worldwide. This should keep you up at night if you're in global health, trying to figure out what's happening next, what's going to appear next on our doorstep. That's a real problem. And we need answers. We don't need blank answers like this, which happened in the era of avian flu. The first time one of them sneezes, cut the rope, so all the birds are another. There were actually people in the Forest Service and the National Park Service who were charged with watching for Canadian geese flying across the border from Canada to find out if they were going to bring avian flu into the United States. You can't shoot enough of these geese down to be able to keep avian flu from infecting our animals. But what do? You need something better than that. If you have time to read, get these two books. Coming Plague and Betrayal of Trust. Coming Plague, Lori Garrett was a reporter for the New York Times. This is a history of all the communicable diseases that we've had over the past couple of years. It's a history of Legionella, history of hantavirus, which used to be just in the Southwest. We have a mutual friend who's a veterinarian that was at Merck. He has a cabin in the Poconos, Bellevue. Every year before he occupies the cabin, he brings in a company who, with a HEPA-filtered vacuum cleaner, cleans his hunting cabin. This hantavirus that only appeared in the Southwest is now in the Poconos. It's present in mouse species. You sweep it, aerosolize it, and it becomes a respiratory virus, and there's no vaccine, and there's no antiviral for it. So think about all these other diseases. So this is about the history. Everybody thinks Legionella is over. It's not. Last year, some people got Legionella at a home show in Oaks, Pennsylvania, because they were exposed to water from a hot tub, from the jacuzzis, which aerosolized the Legionella, and they contracted Legionella because the water wasn't treated properly. So you can get it in a lot of places. You just don't have to be at a hotel in Philadelphia 20 years ago. Marbury virus, how did people get that? betrayal of trust is a fascinating one. It's about how global public health has collapsed. We're not funding the CDC like it used to be funded. When disease outbreak happens, we don't have the people to send to find out that what is called disease detectives. The guy who was head of that group retired. He said, I can't take it anymore. We're not getting any support from the Trump administration. End of discussion. He left. And so that's the problem. Countries that have fallen apart, like Russia, that are not spending money on disease modification and monitoring them, collapse the golden policy. That's a really interesting person. So how do we respond to these things? One way is people are looking at what are called single-use systems. These are disposable bags, pre-sterilized. This one company, Accelerex, now has a 5,000-liter disposable system. You put it into a big holder, like a thermos bottle. The controls are there, the monitors are there, probes are all there. You run your reaction. When you're done, you drain your material out, you autoclave it, you shred it, you throw it in your dumpster. You don't need that $4,000 a square foot building. Maybe you can get by with a $2,000 square foot building. But what it allows is flexibility doing multiple things because everything gets connected together and it's a temporary connection. When you're done, you unplug it and you get rid of the material. So startups are using some of these materials to make some of the vaccines and getting out really quickly. I mentioned tobacco. This is one thing that's been tried. This was built, this is at the University of Texas, Austin. This is a flexible manufacturing facility. So all of the downstream processing is what people are calling plug and play. Each one of these modules is a different potential vaccine. Be able to get in quick and solve the problem. They're using tobacco. I thought maybe you should be using marijuana plants because at least if you grow your vaccine in the marijuana plants, you could eat the marijuana, get high, and you wouldn't care about the disease you got. But you know, it worked out really well. But this again, rapid response. How are you going to come up with dealing with the next emerging disease that's going to pop up? We can't spend 9 months making a vaccine. And that's making a vaccine after research laboratories that try to figure out what's the cause of the agent. That's a real problem. So futures. I'll just quote from Yogi Berra. Predictions are difficult to make, especially about the future. You know, think about it. We've got all these problems out there. Somebody just published an article this past week about the fact that we are actually spending less at the NIH than we have been in the past 10, 15 years. In real dollars, the budget's been going down and down and down. And what is not getting priorities are communicable diseases, especially the diseases not happening in the United States. And that's the problem, is that the uptake and negative comments, people like Jenny McCarthy, former Playboy Bunny, who's a champion for not getting vaccinated for measles, mumps, and rubella, all the misinformation that's out there. AE's associated vaccination programs has really created this anti-vaxxer movement, not in the United States, not necessarily just here, worldwide. Australia's got this problem, many other countries have it. Because these are re-emerging. We once thought we were getting rid of them. We once thought we were actually getting rid of measles, mumps, and rubella, and it's back. We saw these cases of measles. As of this morning, there are almost 5,800 cases of measles in Samoa and 100 deaths. And there's only 200,000 people in Samoa. They've asked people to stay home and put a flag on your door if you've been vaccinated. If you haven't, they'll vaccinate you in your house. They're doing social distancing to try to contain the outbreak in Samoa. Measles is an incredibly contagious disease. If none of you have been ever vaccinated and I had an active case of measles and I sneezed, 15 minutes later, you're all going to be infected. That's how contagious it is. So that's the real worry there. People are, risk-benefit analysis. Americans don't know anything about risk. They certainly don't know anything about benefit. If you knew something about risk, you wouldn't bet on the lottery. Pure and simple. Your chance of winning the Pennsylvania lottery, your chances of getting struck by lightning in a convertible Saab on the Schuylkill is better than winning the Pennsylvania lottery. Vaccines prevent diseases, but we have no historical knowledge. Nobody has seen an active case of polio in the United States in decades. We don't know what it looks like. Fortunately, most physicians don't know what it looks like either, and that's the problem. It's not in our textbooks. We went to that. I worked in Boston for Merck for 5 years. And after 9/11, 2 of the planes left from Boston, Logan Airport. They had town hall meetings with the Department of Public Health. And they were revisiting how they were training emergency room physicians to recognize diseases that might be appearing as a consequence of biological warfare. Nobody's ever seen a case of anthrax in the United States. Nobody had seen tularemia in the United States. These are all diseases that they needed to educate physicians because in some cases, maybe it was a picture in the medical microbiology textbook. Probably not. So you have an entire generation or two of physicians who've never seen these diseases. So that's one of the issues. And it's largely due to childhood vaccination programs in which we almost eradicated polio and smallpox, which was eradicated. The problem is, how do you celebrate the absence of the disease? It's like trying to prove negative evidence. It's really tough to think about. How do you celebrate? So that's the success of vaccination is the public doesn't appreciate it. It's not like I'm going to cure your hypertension. You take a stroke, you won't get hypertensive, you won't die of cardiovascular disease. So that's sharp contrast to, say, antimicrobial. You've got a really bad case of bacterial pneumonia. I give you an antibiotic for 10 days, I cure you. You see the consequences. You don't see the consequences of not getting smallpox because you never see anybody with smallpox except in a textbook. You don't get polio. You don't get yellow fever. You don't get pneumonia because you had Pneumovax or Prevnar 13. Those are the issues that the public is trying to deal with. So I found this quote on Monday, which I thought was great from an Italian physician. The earth is round, gasoline is found, vaccines are safe and effective. All the rest are dangerous lies. Think about that next time you talk to somebody who doesn't want to get vaccinated or fall off line, which is it's hard to unring a bell. And that's, think about it. How do you counter the crap that's out there on Instagram and especially on Facebook about how dangerous this stuff is? Remember Michelle Bachmann, who ran for president a couple of terms, you know, when Sarah Palin, who told us she could see Russia from her house in Alaska? She told the story of somebody coming up, mother came up to her at a rally somewhere in the United States and said, my daughter caught autism from my measles vaccine that she got. She caught autism. That's what's got to be countered. But that is part of unringing the bell. Once it's out there, it's really difficult to dissuade. And most of these groups are not going to understand the sound scientific evidence. So Paul Offit's out there all the time talking about this. He wrote a book you ought to read. It's called Do You Believe in Magic? It's about the supplement industry that many people are using as a substitute for traditional medicine. Milkweed thistle, St. John's wort. How to avoid seeing your doctor. Right? If it's on the internet, it's got to be clean. It's got to be safe. Right? They're using Dr. Google. So this is my telephone number. If anybody wants to contact me, people who happen to be online, that's my email address. You know what this is? It's human chrome. It's a human karyotype. And obviously people sometimes have too much time on their hands because some graduate student did this with gummy worms. Take a close look. Those are gummy worms. And he has a website where you can download this thing. So thank you for your attention. I realize we ran a little bit over, but you know, as I said, being an educated consumer, understanding where we are, where we came from, and what are the problems in the future, especially as we go through emerging diseases, it's just an incredibly important area for you as scientists, whether you're actively still practicing your art or you're consulting, is to just talk to your colleagues, talk to your families. They can then be your mouthpiece to talk about these things, because I get this when my grandchildren come back from school and somebody there rants and raves at a PTA meeting or PTO meeting about these dangerous drugs, these dangerous vaccines. I'm not vaccinating my kids. I like what Seattle. You don't vaccinate your kid, you're not coming back to school. Portland, Oregon. After the holidays. No vaccine? Kids out of here. I don't care. No more religious exemptions. You get vaccinated or you don't show up. Pure and simple.
Thank you.
Thank you for your time.
I'm sorry I had to step out for a couple of minutes. Does CRISPR work with gummy worms?
I don't know. There are probably some ethical issues there. Yes, sir.
Yeah, two issues. You talked about Sir Jeffrey contaminating blankets for Indians, and that basically has been disproved. They didn't need to do that. They caught smallpox just from the native population coming from Europe, because they had smallpox in their system. They were immune, but they never had to. Jeffrey Amherst never had to take care of
partially
that.
killed by smallpox also.
They were killed by smallpox, but not that. They weren't that clever to give them blankets. The second is I worked at Hanford. I didn't glow, and it would have been better off because then people could see it.
You would see where it is, but it's still a
It's a real problem.
Talk about a super fun site.
Oh, it's a problem.
I used to be the RS radiation safety officer for Merck. So my mustache glows in the dark. I swabbed everything that came onto the plant site for both MMD and MRL and MPMD, you name it. So I handled everything that was radioactive.
So I got a technical question.
Sure.
You showed a slide where the first dose of the vaccine gave a certain titer, the second dose gave a
little bit higher titer, right?
Yeah, I mean it looked like a lot more than twice.
Yes.
Is that typical?
Depends on the vaccine and what your immune system responds to. So in the case of something like Merck's hepatitis B vaccine, it may take 3 doses over 6 months. You space those doses out over every other month. It really depends, and that's why when we did these studies, and everybody's done this study, you're looking at 60,000, 70,000 patients, because somebody may double their immune response, the titers, someone may get a really high dose, so it's fine-tuning how much you actually give, and then setting the dosing interval. So that's why you need 70,000 patients. Figure out what's optimal. It's like any drug that we develop as a small molecule. We come up with a dose, 100 milligrams, or 10 milligrams. That's going to get maybe 80%. It's a bell-shaped curve. Your immune response is a little bit more flaky, if you will. And it may take a larger number of patients to figure out what's the right interval, and then how long does it take to get to, say, 20% neutralizing antibody, and then the next one maybe 60%. Maybe even 60% isn't enough for that disease. Maybe you need to have a third dose to get to
I guess what I'm asking is, why wouldn't the effect on the titer be just linear?
The immune system doesn't work in linear, it's a step functions.
Why?
I don't know, Bob? Immune system working in step functions rather than linear responses?
Well, first of all, you're looking at averages for a lot of people. Some people don't respond, some will respond more. And you give a regimen that you know will affect everybody. Some people don't need all the doses, but when you're planning your program, you want to cover everybody. The first shot doesn't bring much response because the body spends more of its time processing the antigen and setting itself up. And that's called the prime. That is a small amount, if anything. And the second or the third shot are called the boost, and that's when, if you can imagine, cells are replicating. So by the second or third shot, you get a geometric growth of cells and therefore higher amounts of antibodies. I'm not sure I answered your question though, because I'm not sure I heard it. I hope I answered something good enough.
Yeah, that's why as we get older, you may need higher doses to boost because our immune system isn't as responsive. So the flu vaccine this year, the one for seniors, is 4 times the load of the one that your grandchildren or your children get.
Interesting, the flu vaccine is not like hepatitis B. When you give a baby hepatitis B vaccine at birth, you're priming them, and then you give them further shots over the first year or 6 months of life. The flu vaccine, you're actually boosting your prior exposure. It's not, it's a completely different paradigm. That's why you usually only get 1 flu shot, because all you're doing is protecting yourself for a narrow window, like 6 to 9 months, and then you don't need it anymore. And you're literally only boosting what you had before, which means sometimes people who are naive, like they've had bone marrow transplant or whatever, they're very susceptible because the flu shot doesn't work as well for them.
Yes, sir.
I have a question. Vaccine, a number of us would be very interested in one for Lyme disease. Does anybody work on that?
There actually was. GSK had a vaccine
Yeah,
for Lyme disease.
there was one that GSK worked on. They called it Lymerix, and there was a adverse reaction to it. Medical term that I can't recall, but also it never sold that much. Adult vaccines, I'm going to ask an embarrassing question. How many of you have had flu shot? Not embarrassing, that's good. Even at Merck meetings, I've asked my hand, and only a third of the people said that. So the problem is pediatric vaccines are legally required. Pediatricians have to do them or they get sued for malpractice. Adult vaccines are notoriously unsuccessful because adults decide they don't plan to get sick, so why should they get vaccinated? And this is an impressive group here with so many raising their hand, but by and large, the Shingrix vaccine, number 1, had this severe reaction, and number 2, basically people didn't take it, even though there were places where Lyme disease was so prevalent.
Well, if it has a severe reaction, I can see why, but if it doesn't, I mean, there are a number of stuff.
But no one's come back with anything since.
No, they developed a vaccine for animals.
Right, for dogs.
For dogs, and that doesn't work all that well either. I remember there were a lot of toxicities and deaths in the dog vaccine. And I have a friend whose dog got vaccinated, and the dog still died of Lyme disease. So it's not totally protected. Again, negative information. You don't see it. Why should I get vaccinated for it?
Talk about thimerosal. Where is it used? And what is the toxicity?
It's not used as much as it used to be because of the whole business with MMR. I think it's still used for the nasal vaccine. There's one version that is used, but it's not the one that's primary. The Flumist doesn't have it anymore. There's some
aerosol not in the U.S.
Not in the U.S., but it is overseas.
No, I think in flu, low-dose flu, in the rest of the world, it's still used. There are fewer lawyers.
Yep.
It says mercury, that's why I break it up.
There's mercury, so that's why there's
Yeah,
so
but
much
you know, the kind
reaction
of
to
mercury
it.
in thimerosal is not the kind of mercury that's
Right.
neurotoxic, and that's the problem. And that, the problem again with things like Instagram and Facebook is what gets out there becomes the truth. That thimerosal is neurotoxic and thimerosal is not neurotoxic. It's other forms of mercury that are. And so that's convinced people. That's why I'm not going to get this vaccine. And in the UK, as a consequence of that paper by that physician, they broke up MMR into 3 separate doses. And it wasn't as effective as 3 separate doses as opposed to one combined shot. Jab is what it's called.
Thimerosal is an interesting, DTP, which is used worldwide, is sold as a multi-dose. It's the only way you can make it cost effective. And therefore it's still widely used. And someone was wondering how reliable was the supply of thimerosal. Because if thimerosal was not available, there would be massive epidemics around the world, not in the US. And it turns out it's made in the basement of some guy in Chile. The whole world's supply of thimerosal is made by this one guy who's getting old, so now his sons are making it. So one of the projects we did with the Gates Foundation is to build a storage facility to hold this stuff so that in the event this guy's home blew up, the world would not suffer a massive DTP out.
GMP basement?
Well, yeah, just the chemicals, so it's not the final product.
Okay, Greg, you have one quick question? I was just curious, what do you think I've seen as the biggest challenges or hurdles as to why we haven't seen an HIV vaccine?
Part of that is, my understanding is that the HIV virus mutates so quickly that it's really difficult. You know, we're looking at memory, taking 5 to 7 days, and you already become infected by the time you would be able to mount the memory. At least that's what Amelia was always told me about an HIV vaccine.
So it mutates faster than the flu vaccine?
So, moving target, exactly. So for those of you who are interested, those are all the targets that people are working on for gene therapy. So, you know, you want to talk about ethical issues? We're making drugs for the United States, Canada, and the UK. Nobody in the third world developing nations can afford these products, and I got $850,000 for 2 doses goes into somebody's eye. So that's becoming the real ethical issue these days. It's not the vaccines that are getting served worldwide, is making products for truly developed nations, and nobody else is able to afford these things. So that's, bioethicists are worrying about that. It's one thing to not vaccinate anybody. You know, Japan has been a net exporter of measles for decades, because only polio, I think, is still a required vaccination for children in Japan. Nothing else is required. So these Japanese kids show up at summer camps, and they all bring measles. Or they go to Disneyland, and they infect everybody with measles who hasn't been vaccinated. Especially on the West Coast, where people don't get vaccinated in Portland, Seattle, areas around Frisco. So
Okay.
I don't want to hold anybody up any longer. So thank you very much.
Thanks very much.
Wow.
We're all
just-
doomed.
Just scratching the surface.
Thank you very much.
Thank you.
Thank you.
My sister-in-law is an anti-vaxxer for giving me toxins.
Oh, yeah.
Evidence doesn't work.
The thing is, it's hard to argue somebody with logic. Hard to argue somebody with logic on a place they didn't get to with logic.
Yeah. I mean, I've actually read some articles about how to convince people without, without using evidence, because evidence isn't working.
And because they've never seen these things, there was a book published